A presentation I did a few weeks ago in Durban at the South African Pain Conference, where I was invited to introduce the audience to the concept of psychedelics, which for many people in the medical community remains still a little bit of an enigma. And Mishka and I spoke about the importance of building bridges between these different communities. And I acknowledge that today in this room there are those of you who work as allied health professionals or medical practitioners. There are also those of you who work with the plant medicines as facilitators or growers. And I think ultimately the best way forward is for us to build bridges between our different communities. That being said, I think there are different needs and requirements and feelings to be safe within these different communities. So I just want to request that we respect those different needs. And for today, I'm definitely going to have to wear the hat of the medical doctor and communicate to you from that framework. My aim is to discuss a little bit what the ethical and legal boundaries are that we are wrestling with and that we could potentially critique. I am not a psychotherapist. I do not currently work with psychedelics. And the aim is not to provide you with detailed how-to guides on how to prepare people, how to integrate them. I think there's a lot of wisdom in the room already, and I hope that in our discussion at the end, that wisdom can also be shared with the rest of us. So the main gist of my talk is to put a few pieces of the puzzle on the table and see how we can put them together and wrestle with them. As Mishka said, the talk will be recorded, so please let's be mindful of that in our interactions. We can be more free in our expression towards the discussion. I also want to request that we respect some of these frameworks as we wrestle and critique them. The gist of my talk is not to break down frameworks. It's sometimes very difficult to put something back together once you've broken them down. So let's try to find ways to be inside and discuss ways of how we can change things. And then also I just want to ask that if you want to promote therapeutic work that you feel might be outside of these reasonable ethical guidelines, to consider that this might not be the platform for those ideas. I think there are different spaces. One day we can light a fire and then we can sit around the fire and have more radical ideas and discussions. So just a little bit of a brief background around myself. Like I said, I don't currently work in the psychedelic domain. I do not get any monetary reward for doing this talk. I also don't belong to any organizations that get any monetary reward. My journey with psychedelics started about 10 years ago with ayahuasca, and I'm very glad that Carlos and Elisma are here today because they were the guides that I had, and through them I've also learned a lot. Both of them are also MAPS accredited and trained, and I also hope to share a bit of their wisdom later today. In my journey, as I became an anaesthetist, I spent a little bit of time traveling overseas. I eventually joined Doctors Without Borders, and I spent a few months working in Yemen on the front line where I saw a lot of pain. And that experience have called me back to Cape Town and to further my career as an anaesthetist in the chronic pain field. And it was through chronic pain that I eventually considered being a more vocal advocate for the use of psychedelics. I come with a lens and a narrative around chronic pain, but chronic pain and mental health are so intertwined. So I feel kind of comfortable speaking generally from that point of view. I'm currently a specialist anaesthetist at Groote Schuur Hospital, where I'm also part of the chronic pain team. And this is currently where I reside, and I enjoy talking about psychedelics, which I feel very passionate about. So thank you for attending the talk today. We recently published a review article in the South African Medical Journal on LSD and psilocybin for chronic nosoplastic pain. So in delving into the research and the literature, I feel kind of informed around what is currently playing out in the scientific literature and the world stage and the intricacies of the narratives around psychedelics. The talk today will be mostly centered towards harm reduction and integration as an ethical and legal framework to work with psychedelics. But before we get there, I thought it useful for us to just in general speak a little bit about what is the history around the legality around psychedelics, what are the psychedelics, and how do we propose that they can work for chronic pain and mental health. And then we can go into the details of harm reduction. So that's just a little framework around how the talk will be discussed or led today. We'll look at some of the legal frameworks that currently exist for psychedelics, and we can definitely critique these. I'll introduce harm reduction as an approach and some of the ethical risks associated with the harm reduction approach and reducing the risks. And then towards the end, I'll introduce you to a new organization that aims to provide a little bit of leadership in this field. And then we can have a discussion where all of you are welcome to share your wisdom and understanding around this topic. So I think psychedelics don't need to be really introduced to this audience, but I love the word psychedelic, psyche meaning soul and delos as revealing. So it's a soul revealing medicine. And in medicine, where we look more specifically towards receptors, psychedelics work mostly on the serotonin receptor. There's 16 different types of serotonin receptors spread throughout the body. And in our understanding of psychedelics, they mostly bind to the 2A subtypes, which is expressed in the brain and also in the spinal cord. The psychedelics can either be organic, so there's like psilocybin, mescaline, DMT, such as ayahuasca or ibogaine. And then we also get synthetic psychedelics, such as LSD, which is based on an ergot, which is a plant fungus, and then MDMA and ketamine. Psychedelics has been used by indigenous communities for thousands of years, and more recently there's been a long history of underground use in the underground movement since the 1950s. And more recently there's been a resurgence in popularity since the early 2000s through organizations such as MAPS and the Beckley Foundation. In general, it's been termed the psychedelic renaissance, which have seen an upsurge in research and interest in this field. Psychedelics and chronic pain and mental health. How do we believe that it works? I like the statement that says the body is mind. So what you do to the mind also reflects in the body. And generally in medicine, there is now this move to move away from the idea of cure and move more towards homeostasis. So what is good for me and what is normal for me is not necessarily what is good and normal for you. And I think medicine is slowly starting to move towards this, to this understanding. So there's a link between chronic pain and mental health, and that's why in psychedelics, the mental health can easily be transferred towards chronic pain. A lot of people with mental health problems develop chronic pain, and chronic pain also predisposes you to developing mental health disorders such as depression, anxiety, and PTSD. There is some evidence for psychedelics to work directly on serotonin receptors in the brain and the spinal cord, which with many pain medications, we utilize the serotonin receptor. But this is not necessarily where currently the thinking around the analgesic effects of psychedelics come from, but more towards this idea that patients with chronic pain and mental health disorders have what we call excessive rumination and overthinking, which traps them in a diseased thinking and narrative mindset. And through the serotonergic effect in the cortex, the psychedelics bind to serotonin receptors, which then deactivates what we call the default mode network. The default mode network being that part of the brain that orientates you specifically to time and place, and it broadly can be seen as the vehicle behind what creates the egoic sense of self. I am Johan based on my historical and ontological narrative around who I am. But when that narrative becomes pathologically ingrained, my disease state becomes part of that narrative. And psychedelics helps to unbundle all of that and relaxes it a little bit so that I can get better understanding and insight around the totality of who I am, also in reference to my external environment. So the psychedelics decreases these excessive rumination, and it also helps to reset some of the cortical regions associated with chronification of pain. Many people with long-standing chronic pain activate specific parts of their brain that creates excessive emotional responses to pain. And psychedelics seems to unwind that process to a certain extent. In the therapeutic context, we have patients in chronic pain that struggle to move towards actionalizing therapeutic approaches. We say that they are being pre-contemplative. So psychedelics can move you from a pre-contemplative, contemplating your therapeutic pathway, to being more action-orientated and being within the therapeutic process itself. So according to the literature, there is various models to using psychedelics in chronic pain and mental health. These might move from microdosing regimes to more of the larger 5-gram psilocybin sessions. But there is currently no standard of care established with the use of psychedelics. And as we all know, they are not currently legal in South Africa. But broadly, we all know that there's, in the therapeutic approach, there's the importance of the correct set and the correct setting, the correct mindset and the correct environment in terms of preparation and integration. So in chronic pain, we follow specifically pathways that are very similar to mental health treatment pathways. Most of these are around what we call psychedelic assisted therapy, or broadly just abbreviated as PAP, and then also ketamine assisted psychotherapy, or CAP. Ketamine currently is legal in South Africa, as is ibogaine. For me, the important thing to highlight here is that the psychotherapeutic component is an important aspect of the psychedelic experience. So it involves pre and post-treatment counseling. So I want to interject here just briefly by highlighting something that happened this week when in the United States, the FDA rejected the MAPS-led phase 3 trials around MDMA-assisted psychotherapy for PTSD. There are various reasons for why they've chosen to reject it, and we can discuss this a little bit later. But what we see is that organizations such as the FDA and the similar component in South Africa, SAHPRA, the South African Health Product Regulation Authority, do not really have the skills to assess a bundle of care around a drug and a psychotherapeutic component, which has very important repercussions for further trials, because it seems like many of the other companies that are looking at psychedelics are now going to exclude psychotherapy as part of the trials. And I think this is very important to take note of. It also seems that there might have been a bit of dishonesty on the side of MAPS in terms of how they reported adverse events. And also it speaks to the difficulty with designing placebo-controlled trials. It's very difficult to give someone a placebo that mimics the effect of a psychedelic drug. These are just some of the reasons, and I think there's we can discuss a little bit later the repercussions and the other reasons behind this. So currently in South Africa, the only legal psychedelics is ketamine, it's Schedule 5, and ibogaine, which is Schedule 6. But all the other is SAHPRA Schedule 7. LSD, psilocybin, MDMA, DMT or ayahuasca, and then mescaline from the peyote cactus. So it's criminal to use, possess, and manufacture these psychedelic drugs. SAHPRA, the South African Health Product and Regulatory Authority, is an authority that is linked to the Department of Health, and these are the guys that are in charge of making sure that whatever is out there in the marketplace is not harmful. SAHPRA themselves do not conduct research trials, but if we conduct research trials, we can approach them and then they will assess the quality of the trials to ensure that they are potentially implementable. So let's have a brief look at why psychedelic drugs are illegal. Why do we need to have this discussion in the first place around finding legal avenues to work with psychedelics? There's been a long history of suppressing non-ordinary states of consciousness, and lies in our colonial roots. Many colonial powers found that if they disconnected indigenous communities from the sacrament that connected them to their spiritual practice, they can destroy these communities and they could suppress them. In the United States, after the abolishment of slavery, was called, broadly speaking, the Jim Crow era, there was a big push to start to use legal frameworks to further suppress civil rights in the United States. But then it more broadly came into focus during the 1970s, during the Richard Nixon era, where the American administration encountered the counterculture movement and the civil rights movements, which were very strongly linked to the use of psychedelic drugs for mind expanding and questioning levels of authority. So the United States have an outsized influence through the United Nations on enforcing their own drug legislation on the rest of the world. And so this started in 1961 with the Single Convention on Narcotic Drugs, and then the Convention on Psychotropic Substances of 1971, and 1988, further United Nations Convention Against Illicit Traffic of Drugs. And in South Africa, the Drug and Drug Trafficking Act of 1992 and the Medicines and Related Substances Act of 1965. So it looks like the rest of the world kind of followed in the footsteps of the United States, which through their embargoes on certain economic patterns can really have an outsized effect on drug legislation in the rest of the world. So our drug legislation cannot be untied to what's happening over there. This study was published in the Lancet, which is in medicine one of the very important journals that we look at, in 2010. It's a study that was conducted by Professor David Nutt. He's a neuropsychopharmacologist in the UK. They got together with members of the independent scientific community, and they looked at 20 drugs and through 16 criteria which related to the harm that these drugs can do to yourself and the harms that these drugs can do to those around you. Because they wanted to get a general idea and to inform the UK Parliament around what kind of thinking should they apply when they conduct drug legislation. At the time, during the psychedelic renaissance and the increased use of psychedelics in the clubs, it seemed that they wanted to understand why there was a decreased use of liquor and alcohol in these clubs. So this study was presented to the UK Parliament, and it showed that the most dangerous drugs to self were heroin, crack cocaine, methamphetamine, and the most dangerous drugs to others, or what you can act on others, were alcohol, heroin, and crack cocaine. But the alcohol lobby group didn't like this study, so a lot of this was actually suppressed and not acted on. But this is a lovely graph that just shows you how disconnected drug legislation are from reality. If legislation is created around protecting us from ourselves and also from other people, then alcohol should in fact be the drug that is heavily criminalized. It's the most dangerous drug to self and others. A little bit further down we see tobacco, also way more dangerous than most of the others. And then way towards the right-hand side, you see the classic psychedelics that we are discussing today. It includes ecstasy, LSD, and magic mushrooms. Way less harmful than any of the other drugs. So when you look at this, you have to ask yourself whether drug legislation actually is meant to protect society from themselves. So which legal frameworks currently exist for psychedelic treatment? And I think this is a very interesting topic of conversation. There's either a medicalized model, or a decriminalization model, or the legalization model. And there are pros and cons to each one of these. Looking towards medicalizing psychedelics, the advantage is that there's improved regulation around the production of psychedelics. But the downside is that it seems to be a big push for corporate capture of indigenous wisdom. Big pharma is poised to take control of the psychedelic movement because there's a lot of money to be made, and they are heavily pushing for a medicalized model. They are also trying to sell this as improved cost benefit. In the United States, it can cost up to $8,000 to treat one person with a major depressive disorder. What Big Pharma is doing is that they're approaching the United States Senate and saying, if you pay us $5,000 to treat a person for major depressive disorder, there's a cost benefit for you here. But in my mind, it doesn't make sense to sell a psychedelic which naturally grows out in nature for $5,000, 100,000 Rand, to sell a psychedelic treatment that should be free. Then there's the decriminalization model, which is the model that's mostly being advanced in the world today. So the advantage is that it treats drug use as a health and a social issue, and it's not a criminal justice issue. The downside is that the cultivation and use of psychedelics is still illegal, and it creates increased barriers to care. And then there's the legalization model. Advantage is improved access, better regulation around manufacturing by the authorities. For me, one of the downside risks of legalization is that you could have at-risk groups that have too much ease of access to drugs, like minors or people who have other mental health disorders. In my reading around this topic, I've come across some evidence that specific groups, especially in Canada, is looking towards a blended approach where you don't have to choose any one of these three models, but that one should rather ask yourself different questions around psychedelic drugs, such as who should have access to the drug? What must a person do to have access to the drug? Should you provide some form of competency? Should certain drugs in certain amounts only be available to people that are of legal age? Where can a person obtain a drug? Are there certain psychedelics that can be obtained in a coffee shop, such as what we see in certain European countries? Or is the quantity of drug, the larger quantity that one wants to buy, should be bought from registered providers or even pharmacies? And also, where should drugs be consumed? Certain psychedelics are only for home use, and other psychedelics can be used at festivals, etc. So I'm asking a question whether a medical, legal, and decriminalization model shouldn't actually have a blended approach. This Canadian group designed a board game which they used to increase public education around psychedelics with different scenarios to try to see where this blended approach of using psychedelics can be best applied to. I thought this was a very smart and playful way to explore and to conduct behavioral science. So what is currently taking shape in South Africa? A question can be asked around whether we are not in the same place with ARVs and HIV now than we were in the 1990s, where brave people like Zaki Ahmed in the treatment campaign were saying government is not coming to the party, so we are going to start to provide ARVs to people who are in need. And so the question is no longer whether it's ethical to provide psychedelic drugs, but rather, is it not unethical not to provide psychedelic drugs to our communities? Because there's good evidence for the use of PAT in mental health, and we are living in the midst of a mental health crisis. There's lots of current studies looking at psychedelic therapy for chronic pain, and the list of countries decriminalizing psychedelics is expanding. We also find that in South Africa, more and more healthcare workers are supporting the use of psychedelics for mental health disorders. And there's also an increased network of underground guides and sitters and growers that want to be better informed and also want to be better trained to deal with these drugs. For those of you who don't know PubMed, PubMed is kind of like the Google for scientists and healthcare professionals. So you put in Boolean operators like psychedelics and pain, and then it kicks out a list of articles. And I took a screen grab of some of the lists of articles that it kicks out. You can see from psychedelics and pain, it starts in 1956, and then you can see how the graph increases towards 2024, which is beautiful to see how the amount of research coming out around psychedelic drugs for PTSD and depression is expanding. Just want to show you some screen grabs of some of the studies. Psilocybin for fibromyalgia, which is a big problem for people in chronic pain. This is a study that's currently enrolling at the University College in the UK, where they're looking at psilocybin for fibromyalgia. Lots of studies around LSD decreasing pain perception at microdoses of around 20 micrograms. You guys are all welcome to, you can access PubMed, you can put in these Boolean operators and it will give you access to these journals. Not all of them are free to use, but you can click on a certain button that says only give me the articles that are freely available. Psychedelics for the treatment of PTSD. There are literally hundreds of articles and lots of studies that are currently enrolling. So let's move towards looking the harm reduction and integration approach, which I would like to put on the table as a current vehicle and avenue that we could use to ethically and legally navigate in order to work with psychedelics in South Africa. So the gist of the harm reduction and integration approach comes down to saying that there's an ethical duty to reduce the risk of harm of therapy. And there's a general duty to attempt to maximize the benefits of therapy. So the harm reduction approach says that if a patient approaches you to want to use psychedelics, that you need to help the client understand the potential risks and benefits of the treatment. You should also help them contemplate alternative methods to reach their desired goals and help them to develop realistic expectations and create intentions that will help maximize the therapeutic benefit, all within a legal and ethical framework. It basically comes down to a patient approaching you and with the request to work with a psychedelic agent, and then being as neutral as possible to test whether they know what they are requesting, what the potential benefits are, and to make sure that if they do proceed, they get the maximum benefit and also reduce potential harm that one might conduct by being ignorant and uninformed. So a simple case study. John is a 45-year-old male with depression and anxiety, and he suffers from severe debilitating low back pain after a car accident. John read about psilocybin in the newspaper, and a friend told him that he can get some from a grower. John asks you as his GP or psychologist if he should take it, and if you can help him organize a session. The harm reduction approach then kicks in, and you ask him, what do you know about psilocybin, and what are your expectations around this drug? Have you considered other treatment pathways before embarking on this treatment request? Have you done enough research around this topic? Do you know what psilocybin is? Do you know what a psychedelic is? Do you know how what a session might look like? Do you have access to the correct information, and could I point you towards a place where you can get the correct information around psychedelics? Do you know how psychedelic assisted therapy works? You should also test your client to see, does he know how much to take? And where do you intend to take it? So test whether they have the correct set and setting. Vulnerable patients who intend to take it in public spaces or maybe all by themselves sitting on top of a mountain might not be the best idea. Who will provide you with a psychedelic? Is it a trustworthy source? And who is going to sit for you? And also help to critique their choice of how to find a sitter with the correct type of attributes. How do we know how to trust or who to trust as sitters or facilitators? And also help them understand how to take care of themselves afterwards, the importance of psychedelic integration. Just to be facetious, I then conducted or thought, if you do not follow a harm reduction approach, and if sometimes someone comes to you as a healthcare worker with this request, your response could very well be, I'm sorry, psilocybin is illegal, I can't support you in using it. You are not allowed to use illegal substances. By asking me to support you in taking the substance, you are incriminating me as a healthcare worker. Or I feel unsafe as a therapist having this type of conversation. If you want to use psychedelics, then I cannot be your therapist. Do you not trust me as your therapist? I know what is best for you. Does this really sound like a compassionate therapist or healer? And is this really what our government or institutions expect of us to respond to our patients? So the harm reduction approach has its origin in dealing with people that are from vulnerable communities, such as the HIV community, where we aim to decrease unsafe sexual practices. Also, it originated in people who are already abusing harmful drugs in needle exchange programs, opioid substitution therapy, and also alcohol misuse in college students. Not to equate these things with people with psychedelics, but to say that the approach of harm reduction and the efficacy that it had in dealing with this provides us with a therapeutic framework to legally and ethically work with people with psychedelics. So the harm reduction approach in psychedelics rests on two things, and that is education and safety. So we provide people with educational material to make sure that they can make informed decisions, to understanding the risks and the benefits of therapy. We critique their understanding of how psychedelics works and that they know the implications of proceeding with the therapy. We could also provide them directly with education. And then we ensure that if they decide to embark on this as a treatment avenue, that they do so safely. You help them think through their plan. When, where, with who, what dose, where's the source? And you assist with critical thinking in finding the correct guide or sitter. For harm reduction and integration in therapy to be ethical and legal, you cannot coerce patients into taking psychedelic drugs. You cannot unfairly suggest psychedelics as being superior to alternative treatments. You're required to be neutral and unbiased when you discuss different therapeutic avenues. You may also not offer the therapy in question. And technically, you should also not provide access to sitters and facilitators. These guidelines come from the literature around using harm reduction and integration as a legal and ethical framework. And for you to operate safely within legal parameters, this is what is required from you as a healthcare worker. For many of you that are sitting in the room on the opposite side of the spectrum, who are the ones that are sitting and facilitating and growing, I think it's important just to have a look at this, because this is where the sticky points and the barriers between us might originate. So let's look at some of the ethical risks of harm reduction. If you are a certified healthcare worker and you are registered with licensing boards, these licensing boards might have different rules and opinions on harm reduction. So they might, the HPCSA, for example, might say, why did you not stop the client from taking an illegal substance? And we don't yet know how the HPCSA, Health Profession Council of South Africa, will respond to a harm reduction approach with using psychedelics. The other risk is criminal. The more involved you are in your patient's care, the more risk you carry. That is why harm reduction approach advises not to supply clients with psychedelics, and also take care with contacting guides or sitters. There needs to be some form of distance between you and the guides and sitters and facilitators. Potential risk is also malpractice litigation, because they might say that you are violating accepted standards of care. And also, what happens if something goes wrong? There's something called on-tech shock. A patient might have a profound psychedelic experience that completely reshapes his understanding of his interpersonal relationships and his work, that is just too much for him to handle. And he might come to you and say, I didn't know it was going to have such a big impact on my life. Why didn't you warn me? And they might hold you as a therapist accountable for the big disruptive effect it has in their life. Also, something else might go wrong in a psychedelic setting, which you as the person that didn't stop them from participating could be held accountable for. And then there are also aspects around your professional reputation, your peers, the general public. And this might be centered more geographically in the type of workplace. I'm sure people living in more rural conservative areas could face more backlash if they were known to be supportive of a harm reduction approach in psychedelics. So how can we reduce these ethical risks with harm reduction? First and most importantly, be educated. Educate yourself on the empirical evidence the risks and the benefits. Psychedelics is not a panacea. It is not a golden bullet. It is not for everybody. So be informed around how to work with psychedelics and stay up to date with the current literature and research. What is the best practice in an unregulated environment? As communities sitting here together today, that's the importance of also holding each other accountable and understanding what best practice is. You should not provide psychedelic drugs to your clients. This is speaking from the standpoint of a registered medical doctor or psychologist or psychiatrist. It's not your place to provide psychedelic drugs to clients. There are other people that are involved in that type of business. Do not coerce clients in taking psychedelics. Also, if you advertise your services, you must take care with the language that could be used in your advertising, because this could potentially be used against you. And be very careful in coordinating services with underground sitters and guides. Take care with recommending specific retreats and destinations. You might recommend someone go to a specific ayahuasca or psilocybin retreat. Things could happen there that could have impacts on your professional standing and accountability. And then also, I think if you want to work in this space, then get trained on working with psychedelic assisted therapy and ketamine assisted therapy. I will introduce SIPSA just now, but before we get that, this week the South African Society of Psychiatrists and Anaesthetists, SASOP and SASA, released a position statement around the use of psychedelic agents, where they firmly stated they believe that it was illegal and unadvisable to work with any psychedelic, since it's not currently legal, although ibogaine is a legal psychedelic in South Africa, and that it was only within the parameters of registered sedationists, medical doctors, and anaesthetists or psychiatrists to use with ketamine. My personal view is that this position statement is rather harsh. It is not pragmatic. It doesn't build bridges. And it doesn't take into account what's currently unfolding in ketamine clinics all over South Africa. This is why I rather support the incentives of SIPSA, which was recently launched. It's a Society of Interventional Practitioners in South Africa, which aims to bring together healthcare workers working in this space to provide better guidelines, better training, to build bridges, and to be more pragmatic in the use of ketamine and psychedelics in South Africa. You are welcome to contact them. There's an email address. I don't know if their website is live yet, but you're welcome to contact them if you want to get more information, if you work specifically as a healthcare worker in this space and want to access some of their training guidelines. And then lastly, just to end off, I believe that there is a legal framework, a legal avenue. We have an incredibly pragmatic constitution and a South African Bill of Rights, and that there is an avenue towards challenging South African legislation to bring it in line with the current needs of our society and to reflect our collective desire to work with psychedelic drugs in a safe environment. Thank you very much.